Greetings and welcome to the Chronic Graft versus Host Disease webinar. At this time, all participants are in a listen-only mode. If you have not already done so, please close all other programs on your computer. You may submit a question via the web at any time by using the Ask a Question feature on the left side of your screen. If anyone should require operator or technical assistance during the conference, please press *0 on your telephone keypad. It is now my pleasure to introduce your host, Jennifer Gillette. Thank you. Please begin.
Thank you, Roya, and thank you so much for helping us coordinate tonight. Welcome, everyone, to our webinar on chronic graft versus host disease. Again, I am Jennifer Gillette, staff social worker at the National Bone Marrow Transplant Link. We thank you for joining our program this evening. Tonight's program will run as follows. Our outline, we will start with Dr. Mary Flowers. She will address what is chronic graft versus host disease, what are the signs, symptoms, treatment, and management. Then we will go to Dr. Mitchell, who will explain what we need to know about emerging treatments and how to manage chronic issues. Meredith Cowden is joining us this evening, and she will discuss living with chronic graft versus host disease and how to personalize your plan. And then myself, I will help give you some strategies and help you learn how to cope and move forward as a survivor. As a reminder, this presentation will be available on our website within a week. You may also request a copy of the slides by emailing us or by attaching your information to the survey at the end of this webinar. Before we jump into our presentation, we also would like to make sure everyone is aware of the great services we provide here at the National Bone Marrow Transplant Link. The National Bone Marrow Transplant Link has celebrated its 25th anniversary of dedicated service this year to helping individuals and their families from diagnosis through survivorship. We work with hospitals, cancer centers, and other organizations to reinforce and complement medical care by providing resources, support, and education. On the side of this slide, you will see some contact information. Please feel free to reach out to us either by email, and if you want information, slides, or if there's any way we can assist you. Some of the programs we offer at the link are our chronic graft versus host telephone series and webinar support, our caregiver webinar series, our peer support mentor program for patients and caregivers, our Second Birthdays Recognition program, and we provide resource books, materials, and referrals. We have an excellent chronic graft versus host disease, which if you are interested, feel free to reach out to us or give us your contact information, and we'll be happy to share that with you. The bottom line is the National Bone Marrow Transplant Link is here to help. We know our work here is not possible without the generous support of our sponsors. So before we start, we also want to make sure we thank the Insight Corporation, the Meredith Cowden Foundation, the Leukemia and Lymphoma Society, and our esteemed Link partners for their continued support in all we do. As we prepare to begin this evening, I would like to make a quick reminder on a medical disclaimer for anything that's shared tonight. Tonight's presentation is meant to inform and support. It's not intended to replace individualized medical advice. The link and the presenters do not recommend, endorse any specific products, therapies, websites, or clinical trials. And the treatments, therapies, products, trials, and websites mentioned during this webinar are provided as a convenience to you and to promote dialogue between you and your healthcare team. Before adding any new approach or treatment to your regimen, make sure you talk to your healthcare team. And now, without further delay, I would like to introduce to you our first speaker, Dr. Mary Flowers. Dr. Flowers is a part of the foundation as to how we have advanced bone marrow transplant as we know it today. We are so honored to have her presenting. Dr. Flowers is the medical director of the post-transplant long-term follow-up clinical service at Fred Hutchinson Cancer Research Center and the Seattle Cancer Care Alliance. She is a member of the Fred Hutch Cancer Research Center and a professor of medicine at the University of Washington. Thank you so much for being with us this evening, Dr. Flowers. Dr. Flowers?
Hello, thank you, Jennifer. It's a pleasure to be here tonight. And I'd like to first start by providing my disclosure here and also indicate that I will be discussing off-label use of several treatments for chronic GVHD. Only recently, there is only one drug that has been FDA approved for the treatment of chronic GVHD, which is ibrutinib. The other treatments still are to be approved. So the outline, as Jennifer indicated, I will be talking about what is chronic GVHD, what are the signs and symptoms, and how is chronic GVHD treated and managed. Chronic GVHD is indeed one of the major barriers of otherwise a successful allogeneic hematopoietic cell transplantation. It results from an immunological assault of the allogeneic graft against the host. It's a pleomorphic syndrome, and by that I mean it has different manifestations involving multiple organs with inflammation, but also fibrosis, which is a scar abnormality formation as part of the clinical manifestation. About 40% will develop this complication after allogeneic transplant. The median onset is about 6 months. 10% are diagnosed beyond 1 year. And the median duration of treatment is about 2 to 3 years, with about maybe 10% or so of patients who are disease-free with a diagnosis of chronic GVHD, more than 7 years, still requiring treatment. It resembles a lot of other autoimmune disease that you may have heard about also, like lupus erythematous, like scleroderma, like Sjogren's syndrome, which is a dryness, significant dryness of the eyes or mouth. The sites most affected by chronic GVHD, and this is 3 different studies here, but they all say the same. Most of the organ involvement is the skin, the mouth, the eyes, the gut, and the liver. But all the system in the body can be affected by, unfortunately, this complication. What are the severe manifestations? And those are manifestations that can severely affect the eyes or the skin. The skin, basically the formation of this scar tissue that can be difficult for mobility, or ulcers that cannot heal. It can, when severe, it can affect the muscle and joint with fixture contractures. It can affect the tube that connects the mouth to the stomach, which is the esophageal, with strict, with narrowing, difficulty to swallow. It can cause short of breath or cough when the lungs are affected, and can also affect the mouth in such a severity that can impact weight gain and mouth oral intake. This is a more pictorial of what I just talked about. I think picture sometimes says more. This is what we wanted to prevent. This is the worst scenario of GVHD. It's when it involves the skin that is involved more than 80% or 9% of the skin, with disfiguration, with loss of the hair, loss of the nails, or mouth so severe that it affects your intake, or the scar formation that impacts your ability to move. So it's difficult to put the clothes on. It's difficult to put the shoes on. It can affect the eyes so that it's difficult to read, to see, to watch TV, to do anything because of the severe activity in the eyes. In the lungs, as I talked about, this is a CT scan showing some find a significant effect in the lung. This is more the severe form. In the incidence, a high risk of who develops most of this complication are people who receive a peripheral blood as the graft, an unrelated donor instead of a sibling that is matched, an HLA mismatched donor, a female donor, especially if they had been pregnant before, to a male recipient, older age. And what's the factor that decreased or is associated with lower GVHD? Is those with T-cell depletion, in vitro or in vivo. So we manipulate the graft to take those T-cells that is important to GVHD. It's given cyclophosphamide after the transplant, which is common seen after the haploidentical grafts, or receiving a transplant from umbilical cord. All those are associated with less risk of chronic GVHD. And what are the assessments? And I bring these slides here because I think it's important to know that there are 10 questions that will be available to you at your convenience at the other times about what the question should ask regarding the manifestation that one would have with manifestation of GVHD. The key elements when one examines a patient, and I know this is a broad audience that is attending this, it's not just to look, but also to touch and to pinch the skin. It's to actually use two light source when looking at the mouth. You need to use a yellow source, such as a flashlight, because it gives you a more visibility about the inflammation, the redness, or the ulcers. While the white light, which could be a cellular phone flashlight from those phones, which gives you a more blue light, and that gives you a more picture of the lichenoid change, which is this lacy-like changes in the mouth. Range of motion with medical photographs, and the lung function. This is very important because this is not an easy test to do, and sometimes patients want to decline those tests, but you can detect lung GVHD before symptoms are present. And that's the most important point when you detect early, because you can prevent progression of that organ involvement, which can be devastating. And then other evaluation, multidisciplinary group, the ophthalmology, the physical therapist, the gynecologist, the pulmonologist, etc. So I'm not going to go through these two slides. They list to you the 10 questions that you should ask yourself. And the primary treatment of chronic GVHD remains corticosteroids. Several other organs have been evaluated for initial treatment of chronic GVHD, but unfortunately, successful phase 3 studies documented no benefit. And here's the study that has been phase 3 trials. So corticosteroids is a drug that is very potent against the allogeneic reactivity that causes damage, but it's increased the risk of infections, of other severe morbidity, such as mood swings, weight gain, moon face, diabetes, hypertension. So it's a drug that has a lot to do with good, but has severe morbidity, and it's a big cost in terms of health. And despite of that potent effect against the immune system, actually 60% of the patients fails to respond to chronic GVHD. Not the patient, but the GVHD fails to respond. So looking at this graph here is that what's the cumulative incidence of someone requiring another line of therapy? It's about 70% people will require 2 lines, about 50% of the people requires 3 lines, and about 20% requires 5-line therapies. So it's a chronic illness. And for you to have an idea, those are at least some of the lists that I put together about the therapy that has been reported chronic GVHD beyond first line. And the only therapy of all those, the only that has been recently approved is the ibrutinib. And this was based only on a study of 42 patients, where 65% of those had best response observed at 14 months, 71% had sustained response at 20 months. Most patients with multiple chronic GVHD involving other organs responded in the other organs. And the most important piece in terms of the science is that we could correlate the biomarkers of the ibrutinib effect on both the B and T cells, which is part of the immune system, that to know it's associated with the GVHD cause. What was the most common adverse event in this trial for 42 patients? Fatigue, diarrhea, cramps, nausea, bruising, and infection. And it was based on this study that the FDA approved this drug for chronic GVHD as a second-line therapy for people who fail steroids. And now it's the most exciting piece, I think, is that in the last 5 years, there has been an explosion of novel therapeutic modalities targeting the mechanism of the immune system that involves T and B and T regulatory cells. All of them, which has been identified now, not only in the animal models, but also starting to rise the evidence in humans. And you can see here these 3 cells. The brown one is the targeted therapy looking at the targeted T cells. And then you can do that in the graft, or you can do that with new therapies. The green one is about T regulatory cells. So it's approach that can increase the proliferation of those cells or the emergence of those cells, such as low-dose IL-2, extracorporeal photophoresis, adaptive therapy, which is cell infusions of these cells or other type of cells that will have a preference to evolve to this type of cells, which by the name called T regulatory, because they have a function to regulate what is dysregulated, which is GVHD, one of example. And the blue cell is the B cells. And these B cells are important because they are not only dysregulated chronic GVHD, but they also can secrete antibodies that can then promote the development of fibrosis, which can cause the fibrotic manifestation of GVHD. And there are now several drugs that can look at the B cells signaling. Here, there is no need to go through this. This is a new slide, and you can get access to that later. But this is at least this agent that now is being investigated, and what is the mechanism of each one are in the first column. In our center, we have actually 3 new therapies that has been now under investigation for initial treatment of chronic GVHD. The one is ibrutinib, which both acts on B and T cell signal, and this is a study, it's a phase 3 trials looking at prednisone plus ibrutinib or plus placebo. The other treatment that is being now investigated, and when I say it's the Fred Hutchinson, all this study has been multi-center trials, so they are being offered in different centers as well. Then tosplitinib, it's a Syk inhibitor, always target B cell signal, again, prednisone plus placebo or prednisone plus and tosplitinib. And the alpha-2 which is an antibody against B cell, which has a complete accrual, and results are being analyzed. So what does one choose? And I'm almost done with my talk, so it's the timing coming. It's the organ involvement, the severity, the coexistent comorbidity. If somebody has heart problems, renal problems, liver problems, that's all taken into account. The risk of infection, if someone has already a major infection, what is the therapy that will be associated with less infection, relevant drug interaction. Many of the therapies cannot be given concomitant to other medication. The intensity of the monitoring needed. Some of the new therapies require more monitoring because we don't want to increase harm without the benefit, and the benefit but cause more harm. And the treatment accessibility, how distant it is from that treatment being delivered, the cost, etc. So in summary, the treatment goals is to adequately control manifestation of GVHD, aim to decrease morbidity and prevent progression to more severe disease, systematically monitor for early signs of manifestation associated with high morbidity. For example, examine the patient or yourself, patients. Do the range of motion. See if there is an decreasing range of motions in the wrist, in the ankles, in the elbows, in the shoulders, and the pulmonary function test. You can be, again, asymptomatic with now signs of GVHD that the early intervention can be crucial. Minimize corticosteroids without losing the control of the disease. Effective treatment should be resulting in durable response, not a response for a month. And we don't want to increase the risk of infection or other toxicity, or even having a negative effect in the graft versus malignancy, which the patient was transplanted for in some cases. The clinical trial usually the only way to advance the treatment, and often the most appropriate treatment for an individual patient. In conclusion, just to wrap up, GVHD is a chronic illness that takes time to manage, and some damage may be irreversible. Early intervention and compliance are important to prevent serious outcomes. Auxiliary care are critical to decrease treatment-related toxicity and improve quality of life, and Dr. Sandy Mitchell will be talking to you about this. So the goal of the treatment is what? Adequate control of the manifestation, prevent more severe disease to develop, and it's associated with acceptable toxicity. Here are some web resources that you're going to have access to that. And here are my last slides of my acknowledgement, and I thank you for your attention.
Thank you, Dr. Flowers. Our next speaker this evening is another pillar in the GVHD world. She has supported the link for years, and her research makes a difference to chronic graft versus host disease sufferers abroad. Dr. Sandy Mitchell is a research scientist in the Outcomes Research Branch at the National Cancer Institute and a board-certified acute care nurse practitioner who practices in chronic graft versus host clinic and study group at NCI. Thank you, Sandy, for being a part of this important webinar this evening.
Well, thank you so much, and greetings to everyone. Thank you for the privilege of being with you tonight. And building on Dr. Flowers' outstanding presentation, I'm going to be sharing with you some options for self-management to improve symptoms, health, comfort, and well-being. So I'm going to explore some options to manage symptoms and to maintain and improve your health and well-being while living with chronic GVHD. And I think, with this webinar, we're looking forward to sharing this information, but also leaving time for the important questions that you all have, and we're seeing some of those coming in on the Q&A chat function. So we look forward to addressing those questions. I've also, the slides are going to be available, as Jennifer indicated, and I've provided to you here in this slide a few good resources available from the link and also available from the National Marrow Donor Program that provide additional detail or elaboration of some of the points that Mary raised and some that I'm going to raise now. So we're going to talk about managing some common GVHD-related symptoms, and then 3 other concerns, specifically peripheral neuropathy, fatigue, and health maintenance concerns. And we're going to move quickly through this so that we do have time for as many questions as we can take. So building on Dr. Flowers' comments about GVHD involving the skin and soft tissues, immunosuppressive therapy is the cornerstone of managing GVHD involving skin and soft tissues. And clinical trials of new therapies such as ruxolitinib and ibrutinib, which Dr. Flowers mentioned, are important. Other treatment options can include extracorporeal photopheresis or photopheresis, ECP it's also called, PUVA, topical immunosuppressants, creams or ointments that contain steroids or tacrolimus, the use of lubricating ointments and lotions, and the use of anti-itch lotions and antihistamines if itching is a problem. If you have tightened skin or soft tissue, stretching, massage, and or physical therapy are really important to maintaining range of motion and physical function. It's also important to avoid overheating because chronic GVHD destroys our sweat glands, and our sweat glands are how we provide a cooling function for our bodies. Similarly, it's very important to avoid sun exposure since this can cause GVHD to flare. In terms of oral GVHD, topical immunosuppressive mouth rinses and ointments such as clobetasol have an important role, as does oral PUVA therapy. Saliva substitutes can help with severe dry mouth, including rinses such as Biotene. There's a couple of medications that we sometimes prescribe as a trial to stimulate saliva production. These are pilocarpine and cevimeline. And it's important to brush your teeth at least twice daily. And for people that have sensitivity to mint and strong toothpaste, we recommend a toothpaste for sensitive teeth or the toothpaste recommended for children, bubblegum flavor, etc. Dental cleanings are also crucial, and fluoride application and fluoride mouth rinses can be helpful in protecting your teeth from cavities. The esophagus, which is the tube that moves food from your mouth to the stomach, can also be dry, and this can cause swallowing difficulties. For that, we recommend soft, moist foods. We recommend that you drink fluids frequently and take small bites. Your team may recommend a swallowing study. Excuse me. In terms of ocular or eye GVHD, an annual ophthalmologic evaluation is crucial. Preservative-free artificial tears can be used And we do recommend the single-use artificial tears. Topical immunosuppressive agents can be placed directly in the eyes, specifically steroid eye drops and steroid ointment, as well as cyclosporin eye drops. Other approaches for ocular GVHD include temporary punctal plugs, and if those are effective, the tear ducts can be permanently blocked. Scleral lenses, also called PROS lenses, can be very helpful, as can autologous serum tears. Certain pain medications and blood pressure treatments can worsen your eye dryness, so it's important to talk to your team to advise if any of your medications may be contributing to this and if there are potential alternatives. There's some evidence that use of omega-3 fatty acid supplements, also called fish oil supplements, may be helpful. And it's important to stay out of windy, air-conditioned, or dry environments, and you may consider the use of special eyewear that reduces evaporation. Prescription medications that may help your body make more tears, again, include cevimeline and pilocarpine. In terms of lung GVHD, Dr. Flowers mentioned the importance of pulmonary function studies at regular intervals, and this can't be underscored enough because once you have symptoms of shortness of breath, pulmonary GVHD may have established itself. So having those pulmonary function studies at regular intervals helps us detect even subtle declines in the airflows, which you may not clinically be aware of yet. One of the mainstays of preventing and limiting the progression of chronic GVHD involving the lung is preventive antimicrobials and antibiotics, vaccinations, including Pneumovax and an annual flu shot, and it's now October, so I want everyone out there to be sure they're talking to their team about their annual flu shot. IVIG supplementation or immunoglobulin supplementation can be helpful if you're having frequent infections and your immunoglobulin levels are low. It's important to report any respiratory symptoms to your team immediately. These can include shortness of breath, wheezing, cough, or difficulty breathing. It's important that you do not smoke, and if you are smoking, your team can advise about smoking cessation strategies. There's good evidence that chronic sinusitis also contributes to worsening GVHD of the lung, and so we recommend aggressive management of chronic sinusitis. Clinical trials for bronchiolitis obliterans or GVHD of the lung represent probably the best treatment strategy, but other supportive care treatment strategies include inhaled corticosteroids, inhaled medications that relax the muscles in the lungs, and two agents, one called montelukast and the other one called azithromycin. For vulvovaginal GVHD, an annual gynecologic exam is very important. Here, again, in this organ system, topical steroids, cyclosporin, or tacrolimus ointments can be used. And at a compounding pharmacy, these agents can actually be compounded into a vaginal suppository, which is very efficient and easy for self-administration and typically better than the ointments. You need to talk with your team about the risk-benefit ratio for using low-dose vaginal estrogens, such as the estering, which may ease dryness. And water or silicone-based lubricants can be used during sexual intercourse. Vaginal dilators, if you're not having regular vaginal sexual intercourse, to reduce the sneaky eye, the webbing or adhesions that can form, and reduce vaginal narrowing. So if you're not having regular intercourse, using vaginal dilators can help with that. And then sexual counseling is important if you're having any concerns about intimacy, which we'll talk about next. Because we know that sex may be the last thing on your mind as you try to manage the challenges of a transplant. But as time goes on, many people do want to get back to as much of a normal life as they can, and that includes resuming sexual intimacy with their partners. The sexual side effects of GVHD and prior treatment can make resuming sexual activity more difficult, and it's very important to discuss your concerns in this area with a member of your team. If your physician or nurse seems uncomfortable talking to you about it, you can request to talk to someone else who will feel comfortable discussing it. But most physicians and nurses working in this area feel very comfortable discussing these issues, as do social workers and psychologists. It's important to note that it may take time for you to regain sexual function after cancer treatment, but if you had a positive and satisfying sex life before cancer treatment, you will likely be able to resume that. In terms of muscle pain, cramping, and joint pain and restrictions, again, the management of these with immunosuppressive treatment or a clinical trial if the diagnosis is chronic GVHD involving the muscles or the fascia. Similarly, physical therapy for stretching and strengthening, as we've talked about, is very important. Heat, massage, or acupuncture may all be helpful. And pharmacologic strategies for muscle cramping, although the evidence in this area is very scarce, we've listed here a few options that can be trialed. These include magnesium supplementation. Even if your magnesium levels are normal, additional magnesium supplementation can be helpful. Muscle relaxants, L-carnitine, CoQ10, quinine, vitamin E, and baclofen. Your team may also evaluate you for possible avascular necrosis, which is a complication of long-term steroids. For peripheral neuropathy, this is a complication that's caused by inflammation, injury, or deterioration of peripheral nerve fibers, and it results in numbness, tingling, aching, pins and needles, burning, shooting, cramping, weakness, or clumsiness. This can also occur as a side effect of cancer treatment, and it can occur directly as a result of chronic GVHD, particularly the fibrotic forms of chronic GVHD. We've listed on this slide a number of other possible causes that are less common but not impossible to see in the setting of chronic graft versus host disease. So what can you do about this very painful condition? First, it's important to ask your team whether a comprehensive neurologic exam and neurologic screening studies and a neurologic consultation would be helpful for you. Your team can consider correcting deficiencies of vitamin B6 and B12 and evaluating you for hypothyroidism. If you have painful peripheral neuropathy, and that's the shooting pains, pins and needles, aching, burning, there's many different manifestations of this. There's a number of different medicines that can be tried, including Neurontin, Lyrica, tricyclic antidepressants. And it's probably helpful to see a pain team or a pain consultation program at least once to see what their ideas are for the management of peripheral neuropathy. With peripheral neuropathy, an exercise program is crucial, and referral to physical therapy can provide specific assistance with muscle strengthening and improving of balance. Falls and tripping are one of the major risks with peripheral neuropathy in terms of safety issues, and so it's important to have those potential risks for safety addressed as falls or trips within the home. Moving on to fatigue. Fatigue is a very frequent complication in the setting of post-transplant. It can endure for months to years, and it's a very frustrating reminder of all that you've been through and what you are coping with now. Families and patients say that it's physically and emotionally draining for them, that it may be very difficult to manage, and they often describe it as a tiredness unlike any other. Fatigue may also be accompanied by limb heaviness, a decreased ability to concentrate, sleeplessness, and/or irritability. So what can you do? Well, the first thing is to talk with your team, your doctor and your nurse, about your fatigue. Low blood counts, sleep disturbance, stress, depression, poor nutrition, infection, and medication side effects can all contribute to this exhaustion. And typically when I see patients with fatigue, it isn't one thing. In fact, we can usually identify about 10 factors that are contributing to their fatigue. And you might say, oh my goodness, that's bad news. That's actually good news, because that means there's 10 targets that we can work on to try to improve fatigue. And typically with fatigue, it's not just changing one thing. It's us chipping away at 5 to 10 different issues that are all contributing their part to the fatigue. A few simple tests that your healthcare provider can perform may eliminate some immediately treatable causes of fatigue, and this includes a blood count to check for anemia or infection, thyroid function tests, and if you've recently been on corticosteroids and then you've tapered off and are no longer taking them, you could find out if you should be tested for adrenal insufficiency. In terms of what we know about fatigue management, energy conservation is important. And by that, what I mean is just learning how to pace yourself throughout the day, saving activities for the times of day when you tend to have more energy. Eating a healthful, appetite-stimulating foods and avoiding dehydration are very important. In fact, dehydration is a major cause of fatigue, and it's something that can be remediated. Exercise is absolutely critical, and there is a body of evidence, a very strong body of evidence, that that moderate exercise improves your energy level. That can be difficult, though, to implement, especially it's hard sometimes to stay motivated for that, and it can be hard to begin and advance an exercise program. Two small tips. One is to find a friend to walk with, but the other one is to ask your team for referral to an exercise trainer, exercise physiologist, physical therapist, or a comprehensive rehabilitation program. That can be very helpful in getting you started. And you can go to pulmonary rehab or cardiac rehab, even though that's not the exact issue. Those rehabilitation programs are comprehensive, and they have an excellent track record of really getting people who may be quite debilitated back up and able to begin, things like biking, like riding a stationary bike or gentle walking. Sleep is very important to fatigue management, and tips include going to bed at a regular time each day, and very important, avoiding daytime napping. Now, much more effective than medication is something called cognitive behavioral therapy, or CBT, for insomnia. Research has demonstrated this is highly effective, and programs in CBT are available at medical centers, at sleep centers, and actually online. So this is something you can do yourself online, and it works. I'm just going to finish up by talking briefly about health maintenance. Continued self-maintenance and screening and early detection are very important. The transplant itself, together with the natural aging process, can put you at higher risk for certain health problems, but these can all be prevented and or treated. General health issues like getting a mammogram, managing hypertension, checking your prostate-specific antigen level, all these things can get put on the back burner when you're dealing with the early complications of transplant and with chronic GVHD. You and your healthcare team can put together an individualized plan for health maintenance and for wellness based on your age and your unique history of your previous treatments. And I won't go through all of these questions. You all can look at those when you receive the slides, but just some questions to ask yourself and to discuss with your team. Things like dental cleaning, pulmonary function studies, sunscreen, skin checks from head to toe for any pigmented lesions that might be changing, and so on. So I think with that, I am going to turn this over to Meredith Cowden, who will present our next section on personalizing your plan for self-management.
Thank you, Dr. Mitchell. We so appreciate all that wonderful information. I'm sure people are very much looking forward to these slides. And Meredith, we just thank you for being with us this evening. The link certainly looks at Meredith as just a treasure. She will draw you in with her story. You will be inspired by her insight and admire her spirit. Meredith Cowden received her Master of Arts degree in Art Therapy and Counseling from Ursuline College in 2011, and she joined Frontline Service Mental Health Agency in Cleveland, Ohio, as an art therapist and counselor 6 years ago. Meredith is also a cancer survivor who recently celebrated her 16th anniversary of her bone marrow transplant, which cured her of her acute her AML. So anyway, thank you, Meredith, for joining us this evening. We are so excited to have you share your experiences and your stories with us.
Thanks, Jen. So, hi everyone, I'm Meredith. So please let me know if I fade in and out. That might happen here. So I'm going to try and shove as much information as I possibly can in a brief amount of time. So the slide you're looking at now is about my family's foundation. Once I was diagnosed with chronic GVHD, my family, this was back in 2001, so my family was like, hey, we can't find any information about this that we can really understand, so let's figure it out ourselves. This is kind of how we worked. So then they created the Meredith Cowden Foundation. I was not in agreement with the name, but that's beside the point. So we do have a variety of different fundraisers, and one of the goals that we have is we have symposiums that present information currently regionally within kind of, the Midwestern area that we are in around Ohio, but the goal is to ultimately get to a broader audience and go across the country. We have, one of the goals is to combine physicians, clinicians with patients, and so there's a joint conversation that happens, and then more information and more education is provided in that manner as far as we're concerned. So here are the things that I'm going to do. So I'm going to, like I said, shove as much information as I possibly can in a short amount of time. So I'm going to talk about myself for a hot minute, and then I'm going to just give you some ideas and thoughts that I've used that have been effective for me as far as managing chronic graft versus host disease, as well as maintaining a meaningful life. So I was around 19 years old when I was diagnosed with AML. And so then in September of 2001, so that tells you I'm 36 now, right? So in September of 2001, I had a bone marrow transplant. My sister was my donor, and that was fantastic because it was a perfect match and it was great. And then, so I got through my 100 days, and that was great. I did really well through that. And then maybe 4 or 5 months later, I started to get, a red, painful, burning rash on my skin, and I had some, my gastrointestinal system was down. So I saw my doctor, and then the thing that happened is he said, okay, well, Meredith, you have chronic graft versus host disease, and so we're going to give you prednisone. Hey, so I got some prednisone, and that, what it does, as we were talking about actually previously, prior to this, is that it's kind of like a magic drug, but not, because it takes care of the symptoms immediately, but then in the long run it creates some problems and some issues and some lasting effects. So, one of the things that I oftentimes recommend to people that I talk about is, with this process, a lot of it has to do with taking care of your emotional health and your emotional and mental well-being, and there are a variety of ways that you can do this, and I'll talk about that in a hot second. So I got graft versus host disease, and then over the last 16 years or so, it's been kind of the roller coaster of the up and down, and you're doing really well and things are great, and your symptoms are declining, and then the doctor tapers off the prednisone, and then symptoms come back, and so it becomes really challenging. And I think that, one of the things that I personally experienced within, the creating your new normal. Like, what's your new way of life? Like, how do you live currently? And I think that question is something that frankly applies to anyone in any capacity, because what's normal for you when you're 10 is likely not going to be super normal for you when you're 40, right? So it's actually really about creating what's normal for you each day, it might change. So maybe 3 months from now, what's normal right now is not normal then. And that's okay, and that's completely right and appropriate. It's really just a matter of listening to yourself and, being self-aware and paying attention to how you feel and addressing that. And so that's, one of the things that I did throughout the time period. So it's been 16 years since my transplant, and so I still take small doses of prednisone. I'm still on steroids. Please don't take that as typical. It's not. Chronic graft versus host disease is something that, your immune system, which is new, right, is working really, really hard. And so oftentimes it burns itself out somewhere between 5 and 10 years. There are always exceptions to this rule, right? So I know someone who had chronic GVHD for about 3 years. I know someone else who's had it for about 25 years. So it's personal to every person and each individual. And so part of that, I think, that I found was creating a plan for myself and something that was meaningful and appropriate for me, because the disease is not a textbook disease. It's not something that, you can kind of line up all the criteria and they all fit everybody. They don't. It's different for everyone. Things that I experienced, you may not have. And so what I found over the last several years is that, so I was experiencing the roller coaster, and then I kind of plateaued, and there was a time when I felt pretty good for about a couple of years or so, and then I got really, really sick, and that was kind of devastating for me. And so with that, my emotional health was pretty bad. I got really anxious, I got really depressed, it was really difficult, and I met with several different doctors. And so, I think that along with that, it's really important to maintain that. Going back to what I was saying earlier, is that what's normal one day may not be normal the next, and you just kind of have to go with it. Nothing that you're experiencing is going to last forever, for instance, and things are going to change. And it's a matter of, paying attention to your body and yourself, being self-aware, and, listening to your body. And so one of the things that I did that I, hope is helpful for other people is so within this context, so the experience of chronic graft versus host disease is something that is likely for a lot of people something that's uncontrollable. You can't control it. You can't decide, I'm going to be great this day, not so great the next day. You don't have any idea of control for that. So then focus on the things that you can control. So what I did for myself, and hopefully this is helpful for you, is that I focused on, okay, I can manage what I do during my day, and I can pay attention to when I feel the best that I feel. And so what I found was that I felt the best after, like mid-morning, and then I did some yoga, and, that made me feel better, because with that, yoga was one of the exercises that I found that I could do without getting exhausted and feeling like in a lot of pain and somewhat completely worthless. You know what I mean? So, so doing the things that are meaningful and meaningful for you, that give you energy, but paying attention to when that happens throughout your day. Structure your day so that it fits everything that you need. Because really, this entire thing is about you, and as people say, finding your new normal and creating your new normal and all of that. And really what I think it's about is relearning your life. Relearning how to live your life in a way that is best and most meaningful for you, and owning it. I think that one of the times I found that I can't pinpoint it. I don't know the specific date or time when it happened, but that I kind of shifted my thinking, was that I stopped letting my illness define who I was. And I defined who I was. So rather than being the sick one, or, you know, the woman with chronic graft versus host disease, or that one who had leukemia and now has this other thing, you know, then I at some point, I'd love to know the day. I'd probably tattoo it on myself. But, you know, I mean, so at some point in time, I shifted from allowing the illness to define me to defining myself as a person with these other things that I had to deal with and that I still deal with. And okay, that's part of my life. That's what I do. And, you know, sometimes it really, really sucks and it hurts. But I can do the things that I can do within my capacity to control what I can. So I can manage my time. I can manage who I spend time with. I can, you know, focus on what gives me energy. And when I say energy, I don't mean like you run a marathon or 5 marathons or the Ironman or whatever. I mean like what energizes your soul, what gives your spirit, what revitalizes your spirit. What is that thing? Find the thing and do that. Find the people who do that and spend time with those people, because that's really the thing that's going to help you manage to get through all of these, you know, the symptoms and all the stuff that's going on, which is a lot. You know, listening to what, you know, Dr. Flowers and what Daniel was talking about, there's a lot, but there's also a lot of other stuff outside of that. And so who are you outside of that, and how do you live your life outside of it? And focus on what you can control and, you know, what matters to you and how you can live your life. You know, lastly, before I stop, because I think I'm probably over, but, you know, one of the things that I found was really helpful for me was, you know, exactly things like this. Learning, doing the research, finding out as much information as possible for me that was important to me. And so once it's, you know, it kind of goes back to a whole thing of what's the why. Like, so when I work with the people who I work with in my job, I oftentimes think about, like, what's the why? Like, what's the thing that happened to cause this? And so that's kind of where my head naturally goes. And maybe that's not where yours goes, and that's totally fine. But find the thing that interests you and that you need to learn about to help you understand and to live a meaningful life for yourself with this, not as this, but with it, if that makes any sense. So with that, I think what I'm going to do now is turn it over to Jennifer Gillette, who's a fantastic person, I have to say. I really, really appreciate her. She received her Master's of Social Work degree from Wayne State University, and she served as the manager of oncology social work services over Providence Hospital and Providence Novi Hospital for 20 years. Her research and programming led to national recognition at the Association of Community Cancer Centers, and she's been honored to be the staff social worker at the MBMT Link for over a year, and she does an excellent job. She has a passion for connecting people to the resources that they need and for helping them navigate through chronic illness and kind of figure out the road there. So with that, I'm going to turn it over to Ms. Jennifer Gillette. Jennifer? Are you there?
I'm sorry. Here I am. Can you hear me now? Hello?
Yes, that's perfect.
Oh,
Yes.
Thank you. I'm so sorry. We're having a little technical difficulty there, but I just wanted to thank you so much, Meredith, for sharing your story and for your kind words. I have a mutual admiration here for you, but I thank you. I'm sure your story is going to stick with everyone this evening. And I'm just going to add a couple insights. I think Meredith and I are piggybacking a lot on each other's. I think our social work counselor minds are very much alike. One tip I wanted to share with everyone tonight that I've learned over the years is making sure that when it comes to coping that you're setting realistic expectations. Our expectations are the frame or glasses we choose to put on as we look at how we are interpreting something happening to us. If you walk into a situation informed but still hope-filled, you're more likely to have a stronger ability to cope with the challenges thrown at you. If you walk into a transplant thinking that you will be back to life as you normally lived it a couple of months ago, you will find the doors opened a little too fully for disappointment and distress. Talk to your healthcare team on what you are to expect. Your story is unique to your situation. And I'd like to add there, too, that, sometimes we hear stories from other people, and people have the best of intentions, but sometimes those stories can be scary, and their story might not really be related at all to what we're about to go through. So it's really important that you're listening to your healthcare team on what your story is going to look like. However, I will also say that at times it's good to reach out to other people that have had a positive experience and hear what it's like for them. Here at the link, we have our peer support program, and those people are trained, and they're not going to just be sharing scary stories. They've survived and they've lived through, and they have a lot of wisdom. So if anyone is ever interested in that, please reach out to us. But keep in mind, every story is different, and there can be bumps along the way that were not predicted, but having a glimpse sometimes of what a good story looks like can certainly help you with hope. When we talk about coping with people after a transplant, you will often hear people talk about developing a new norm. This term serves as a blanket statement for the many adjustments that one makes as they learn how to adapt to their body as it recovers and how to adjust to the changes in their life as a result. In the beginning, when one goes home, the new normal might be a day of rest with a shower, if you can even handle it. In time, the body gets stronger and you start reclaiming more and more of the life you knew. So your norm keeps changing. It's not really until the first year has passed that people see what their body's new norm really is. This first year is so full of emotion. Your identity can be shaken. You grieve the many losses you have experienced, and the emotional experience of going through this process can further drain your energy and cause depression and anxiety. However, this time can also be a time of beauty. As frustrating as it can be a time where you learn new skills. It's a time to recalibrate and reprioritize what matters most to you in life, and it's an opportunity to have relationships grow to a depth that they had not before. However, this can take time. This is not something that happens overnight. When I first came over to the field of BMT from oncology, I remember talking to one of our board members who had spent a great deal of her career dedicated to research and treatment of those coping with a bone marrow transplant. I asked her, what is one of the best gifts you give patients when you counsel them? And she shared the gift of and. She explained it as this. She said, yes, I may be feeling weak. I may have some challenging symptoms. However, I am also getting stronger. I do have a wife standing beside me, and my children are growing into beautiful adults. As you adjust to your new norm, always look for the and. Despite what's happening to you, there are ands. There are glimpses of beauty and growth. As your strength grows, try your best to reclaim pieces of your life, no matter how small they may be. I remember a very dramatic change I saw while counseling a patient some years back. This woman came to my office with her eyes filled with tears, sharing the grief she experienced as a mother with cancer. She was so weak, and her cancer had led her to needing a walker. She shared how she felt that she no longer acted like a mother to her children, and this devastated her. She was the kind of mom who was always very active with her kids, and caring for them at home made her feel fulfilled in life. As we processed what areas were affected, One example she gave me was that she no longer could do their laundry. She could not climb stairs, she could not carry baskets, and make the process work. After some brainstorming, we discovered that she had a first-floor laundry. We had her husband go purchase a cart that allowed her to do small portions of the laundry, bringing it to the couch, folding it, and then she would have her children take it from there to their rooms. Although this might seem small, this approach made such a difference to her that it started to transform how she did other things as well. She looked how she could adapt and do what she could instead of focusing on the many roadblocks. Her children still knew how much she loved them, but she had to be creative to find ways to show it in ways that were meaningful to her. Along those lines, try to be aware that everyone that loves you walks this journey with you. Everyone may cope differently, but try to take time to check in and see how you can support each other. Try to even check in once a week and just see how everyone's doing and look at what adjustments can be made to help everyone stay strong. There's no weakness in needing breaks. We just finished a wonderful caregiver series, and I would encourage you to review a webinar presented by Michelle Bishop on our website. She provided many great strategies to help caregivers cope. I also had a family I counseled one time who I just loved their advice. They said they would take weekends where they pretended that cancer, bone marrow transplant, none of those things existed. And although the mother who was dealing with the issues, of course she knew deep down inside it did, but they would do everything in their power to try to act pre-cancer what their family was. Another important skill to learn through this is knowing how to ask for help. You cannot be an island during a bone marrow transplant. Asking for help can go against the very grain of many of us. I'd be a very wealthy woman if I had a nickel for every time a patient told me, but I help everybody else. The hard part is there are times in life when we need to receive. It does not make you selfish. Frankly, others need to learn to give back in this world too, so we deny people the chance to grow if we never allow them to give back. So moving forward, it's important that you set meaningful goals. Be proactive in fighting depression. If you feel a sense of gloom or heaviness for more than 2 weeks, tell your doctor about it. See what they can do to help. And find ways to still experience joy and hope. Try to engage in physical activity. Stay active in your healthcare decisions. And try new strategies for coping. You've never been through this before, or at least most likely you haven't been through a bone marrow transplant before, so you probably need to amp up your toolbox and learn a few new things, because this is big. Set a daily schedule to feel more in control, and don't see failure in challenging moments. They are a part of the journey. It's also very important that you communicate with your healthcare team. Develop a system to stay organized. I have been known to be the binder queen, and I highly recommend it to anyone that has that particular style, because there's going to be papers you're getting left and right, and it's nice to have an organized system to keep that way, and it makes it easier when you're sharing it with other people on your team. Communicate clearly and honestly with your providers. Keep a running list of symptoms, health status changes, and new questions, and be a strong advocate for yourself. Have a medical coordinator of your care, especially if you aren't in a position to be able to advocate for yourself right now. Having one person that can be that filter is so very important. Copy other healthcare providers on emails, and use the whole team. I know at the center I worked at, we had nutrition, we had nurses, we had doctors, nurse practitioners. We had all kinds of people on the team, and all of them offer something unique to support you. So make sure you're utilizing that. And don't give up. There is hope, there is support, and there are ways to reach it. And sometimes you just need to keep asking until you get the right answer, or until the answer that helps you. Now, this concludes the information part of our evening. We have shared a lot with all of our speakers, and we'd like to switch gears and try to get to the many questions we have this evening. But of course, before we do that, I would like to just make note of this slide and thank our esteemed link partners. We have wonderful supporters that make all of our work possible. And just in case anyone decides to hop off the line before the questions are completed, I also want to remind you that there is a survey at the end of this webinar that will enable to help us with future webinars to develop high-quality programming. It's also another place you can put your email if you want any information from us, including the slides. So as we gear up for our questions, the first one I would like to give to Dr. Flowers. We received a question that said, is there a relation between Guillain-Barré syndrome and chronic GVHD?
Yeah, so thank you for the question, and thank you again, Jennifer and Meredith and Sandy for the wonderful presentation, and just tell us it takes a village to overcome difficulties and the challenges, but it also makes us stronger as a society, and in science that's no difference. So Guillain-Barré syndrome, yeah, Guillain-Barré syndrome is thought to be an immunological problem. So there are patients who have developed Guillain-Barré. The difficulty it is to actually link that to the real chronic GVHD manifestation or a diagnose that would happen regardless of having a transplant or not. Very difficult question to answer. I'm glad that you brought it up. It's the same thing about myasthenia gravis. Also, that can be, it's an autoimmune disease, and when it happens and we don't know what to blame that to, then by exclusion we say it's GVHD. But it is a hard one, and that's why it's considered a typical manifestation.
Okay. Thank you, Dr. Flowers. I'm going to give you another one, and then I'm going to be trying to spread them out because we've got all kinds of great questions coming in here. But one for you, Dr. Flowers, is what are the effects of long-term prednisone? Does muscle wasting, cataracts, diabetes ever get better? So kind of a two-part there.
Okay, yeah. The muscle wasting definitely can get better, but it can get better not just by stopping the prednisone. It will require exercise to build up the muscle back, but it can get better and resolved. The cataracts, it does not get better. It will just need the surgery for replacement. And what was the other question about steroids? The diabetes. Yeah, most of the people who becomes steroid-dependent diabetes will resolve, but that also depends on the background of the patient. If the patient is, depending on the age, as you know, aging also in weight is a predisposition for diabetes. So in general terms, yes, diabetes should be resolved after cessation of steroids unless other risk factors are already in place.
Thank you, Doctor. This one's for Dr. Mitchell. How can one distinguish between symptoms of chronic graft versus host disease versus symptoms caused by chemotherapy and radiation damage?
That's a great question, and it certainly is sometimes challenging to do. Sometimes it's easier to do because we know that certain kinds of manifestations, like thickening and tightening, for example, of the skin and the muscles, it is not a manifestation of radiation side effects or chemotherapy side effects, but sometimes they do overlap, as do sometimes long-term effects overlap with chronic GVHD. The other challenge is that chronic GVHD, we sometimes call it the great mimic, because it can be mimicked by things like infection, for example. It can also be in the skin, if you have a skin rash, mimicked by, for example, an adverse drug reaction. So it is important that the team kind of sort that through to determine if it's chronic GVHD or something else. Sometimes we can do that through various types of diagnostic studies and biopsies. Sometimes we can only do it via exclusion. Sometimes we can only do it by treating something and seeing if it actually gets better, for example, with a GVHD medication like steroids or tacrolimus. So it can be a challenging effort, and it's always good to not just assume because you have GVHD that everything you're having must be GVHD. Similarly, if you are having a problem and it's good for your team to consider, could this be a GVHD manifestation? Sometimes that's also where seeing a specialty team can be helpful, particularly if you have a very rare or unique manifestation of graft versus host disease, for example, graft versus host disease of the kidney.
Thank you, Dr. Mitchell. Meredith, I wanted to jump to you as well. I have one question here that I wanted to ask you, but I have a feeling you might have something to add as well to the diabetes portion that Dr. Flowers was talking about. But the first question I wanted to ask you was, how do you help others understand the hell of chronic graft versus host disease when outward appearances look mostly normal and healthy? I'm often accused of being lazy or not wanting to do anything by my spouse or caregiver. Sadly, they are burnt out with my problems after 4 years.
Right. So that's an excellent question. That's a fantastic question, and it's a typical question. It makes a lot of sense, right? Because with chronic graft versus host disease, oftentimes people look healthy, normal, fine, fantastic. And it's kind of like another autoimmune disorder, such as chronic fatigue syndrome or something along those lines. And so I think that as far as that particular situation goes, if there's someone who is not necessarily being supportive or accusing you of being lazy, I think that, with that issue, a lot of it has to do with the education, and a lot of it has to do with, so maybe perhaps if that's a partner, that's spouse, whoever, friend, family member, whoever it happens to be, bring that person to an appointment, and, depending on what's happening, maybe it makes a difference coming from somebody else. I know that sounds kind of awful, but sometimes that's actually the truth. So if the doctor explains, okay, this is what's going on, then perhaps that person can understand. I once had, at one point, my oncologist spoke to me, and he said that he did something. He did some kind of, I forget what it was, but he and his fellow doctors, so what they did is they got on treadmills with weights, and they had to walk such a far distance in so many miles with, weights on them. And it was described to them as, this is what it is like to live with this type of fatigue or this type of graft versus host disease, so they could have an understanding of what's going on. I'm not saying to do that with whomever by any means, but there is that kind of level of knowledge when you work with your team, your treatment team, and they can help somebody else understand. And I think at the same time, it's having those really open conversations, and perhaps having, when you meet with someone at the clinic, wherever you go, with your doctor, social worker, counselor, whomever, have that conversation with them that it's, it's difficult to explain, but it's a reality. And, and then along with that, I would also, suggest to a person to have a very significant and large support system around, in addition to, that one particular caregiver, have other people too who have a sense of knowledge. And that's where support groups and, other types of groups come into play, And, you know, there are a lot of different agencies and organizations that have support groups, therapeutic groups, where you can talk with people who understand and who can relate to you, because part of it is relating, right? So if you have someone with you who can relate and understand, and then in addition to that, also have the people on your treatment team help, you know, your caregiver or whomever the person happens to be, you know, then hopefully that will help that person to understand. And I think that, you know, if hopefully they do, and I wish that that person does, you know, I hope you don't hear my cats in the background. That's what's happening right now. There's a fight. But so, you know, be really open, be really honest, be really clear about what's happening and what you are able and not able to do. Have the backup of your treatment team as well as the support group. And I think that that will definitely make a difference.
Oh, I'm sorry.
No, you're fine.
That is great advice there. This one is for Dr. Flowers. How much of GVHD is a good thing?
Yeah, that's a good question. Hello?
Yes, you are on.
Okay, good. There has been studies looking at that question, and I can tell you that when we look at the severity of GVHD, severe GVHD, there is no good. There is no benefit of knowing what is the minimum GVHD that it will give one provided the benefit without the detriment effect. So, but we do know that overall, when we look at the statistical, which does not mean necessary translate into one individual, statistics for us to understand the big picture. Individuals that it is either 0 or 100. There is no 30%, 85%. So in terms of that, I would say that in terms of severe GVHD, mild, moderate, severe, the mild has the best outcome, the moderate and intermediate, and the severe is the bad outcome. In terms of looking at, let's say, mortality or relapse. So that does not mean that everybody with severe only will not have the benefit. Some people will have the benefit, otherwise they would not be surviving, otherwise they did not have a transplant. So I don't think we know how much GVHD can be a good thing. I would say mild GVHD would be a good thing.
Okay, thank you. Dr. Mitchell, could you speak about the long-term effects of seizures or heart issues with chronic graft versus host?
The long-term effect of seizures?
Yes, we had a question. Someone was asking about seizures or heart issues.
So those are two obviously very distinct set of situations. With respect to seizures, those are generally would not be something that is in any way related to chronic GVHD or its treatment. Now, certainly post-infection, especially if there's been infection in the central nervous system, for example, some individuals will be left with a chronic seizure disorder in that context. So it's a little bit hard to say too much more than that. It's certainly not a direct manifestation of chronic GVHD, and it's not caused directly by the treatment of chronic graft versus host disease in general. With respect to cardiac issues can be both related to GVHD, although that's a very uncommon manifestation of GVHD. More commonly, some of the cardiac issues that patients will experience can be caused by the treatment of chronic GVHD, and they can certainly be caused by the primary chemoradiotherapy treatment of the underlying malignancy. excuse me, as well. You know, the whole aging process, I always say to patients, you know, unfortunately a transplant doesn't stop the aging process. And so for all of us, as we age, cardiac risk factors become more prominent, and certainly that's also where family history can be very important. So cardiac factors are definitely critical in the area of chronic GVHD and post-transplant. And as we kind of unpack what is meant by cardiac issues, and this would be a bigger conversation with a member of your direct treatment team who knows your risk factors, you know, the type of primary treatment that you had, et cetera. But we kind of separate that into managing things like hypertension, managing blood lipid levels, which are very important, and any type of interventions that need to be done in terms of either medications or procedures to keep the blood flow to the heart functioning well, and to keep the heart muscle itself, which can become weakened and damaged, to keep that heart muscle in its optimum condition. And by that, what I mean is managing high blood pressure and also managing what's called pulmonary high blood pressure or pulmonary hypertension. So this is a very complicated set of issues. And if you're having cardiovascular difficulties, I would very much encourage your team to refer you to a cardiologist who is interested in the care of cancer survivors. And those individuals have a lot of expertise to add to your management.
Okay. Thank you. Dr. Flowers, did you have anything that you wanted to add?
Only one thing regarding seizures, you know, as Dr. Mitchell indicated, seizure is not a manifestation of chronic GVHD. Seizures most of the time is associated with some interactions regarding medications that one may be given for GVHD, such as, for instance, the calcineurin inhibitors, cyclosporin, tacrolimus. Those medications can lead to hypomagnesemia, which is low magnesium. Low magnesium can decrease the threshold for seizures, and one could develop that. But seizure is a symptom, and usually there is other causes behind it that can explain that, but not GVHD.
Okay, thank you. Dr. Flowers, I have another question here. Someone had asked, beside the 100-day timeline, what are the biggest differences between acute versus chronic GVHD?
Yeah, that's a good question. The manifestation of chronic GVHD can be completely inexistent in acute GVHD. So what that would be? For instance, the oral, the mouth lichenoid manifestation, which is the white areas, the sicca, the dryness, the new dryness, the sicca in the eyes, the sclerosis, all those are a difference between acute and chronic GVHD. So there are specific manifestations that more resemble autoimmune disease, which acute does not. So acute is usually an inflammatory problem that affects the skin, redness, a rash that it's red, the liver, which is inflammation of the liver, or gut, nausea, vomiting, or diarrhea. Those manifestations can be present in chronic GVHD, but alone those manifestations are not diagnosed of chronic. So you have to have manifestation that resembles more an autoimmune disease. This is the major difference.
Thank you, Doctor. Dr. Mitchell, we have one more that I was hoping you could answer for us. One writer sent in this question: will dry eyes eventually resolve, or once the world is cloudy, are you stuck?
Well, it's a very good question. The dryness itself typically will not improve without some kind of management. It's caused by damage and scarring to the tear ducts, and once that damage has occurred, that dryness isn't going to go away except with management using some of the strategies that we talked about. Certainly, if medications are contributing to the dryness, as those medications can be discontinued or changed, that will help with dryness. In some people, they will describe some improvements symptomatically in the dryness with some of the therapies that we talked about, including the use of omega-3 fatty acid supplementation. So we have with the eyes sort of two goals. One of them is to implement strategies to settle down active inflammation so that the tear duct scarring doesn't get worse. But once that it is already present, typically it does not reverse itself. Now, when you mention the cloudiness, that can be part of the manifestation of dryness, right? But cloudiness can also be caused by other eye health issues, including cataracts. So it is very important, anyone who's post-transplant, whether you're having known eye problems or not, it's very important that you see the ophthalmologist annually to be evaluated, because cataracts, something called glaucoma, which is an elevation of the pressures within your eye, as well as infection within the eye, as well as eye dryness and active inflammation from GVHD, and from just irritation because you don't have enough tear production. All of those issues can be at play. So the eye is a very important organ to have routine surveillance performed on that organ at regular intervals. As well, scleral lenses can be a very big help, and we mentioned that in the presentation, the pros lenses. Scleral lenses are definitely something we encourage people to think about, and that can be a total game changer for people in terms of the sensation of dryness that they experience.
Thank you. Thank you so much to all of our speakers tonight, Dr. Flowers, Dr. Mitchell, and Meredith. We have all gained so much from this, and I hope that everyone listening tonight got much to take and put in their toolbox as well. We thank you for joining us this evening, and on behalf of the National Bone Marrow Transplant Link, we just wish you the best and let us know if we can help you any way we can. Take care and have a good night.
Thank you.
Good night, everybody. Best wishes.
You may disconnect your lines at this time. Thank you for your participation and have a wonderful night.